Hello, let us continue with our session on diagnostic stewardship in fungal infection. Let's learn about systemic fungal infection. We'll start with a case. A 40-year-old HIV positive man attended OPD, having disengaged with HIV care several years previously. He was generally well but reported an emergence of a painless mass in the right. Differential diagnosis of this case includes molluscus, vasculitis, folliculitis, and lab diagnosis performed was skin biopsy and serum or CSF cryptococcal antigen testing. In-tank preparation showed a halo of capsulated Cryptococcus skin nodule was identified, which looked and hence there was a look for disseminated cryptococcosis. Now, what are the risk factors for invasive fungal infections? Neutropenia less than 500 neutrophils per mm cube, or hematological or non-hematological malignancy or transplant recipients. Use of steroids in acute bronchopulmonary aspergillosis for 3 weeks. They are on biologics, severe immune defense. Premorbid factors includes diabetes mellitus, renal failure, cirrhosis, immune deficiency syndrome, burns, degutis ulcers, bowel surgery, IV catheters, and steroids. So these are the risk factors for invasive fungal infection. Let us understand the clinical manifestations. In Canada, it is fever and chills with hemoptysis or asthma-like symptoms, chest or joint pains, headache or eye symptoms, night sweats, weight loss, skin lesions. While in mucormycosis, it is a one-sided facial swelling most of the times, headache, nasal or sinus congestion, black lesions on nasal bridge or upper inside of mouth, fever. While cryptococcus can manifest either through pulmonary mode or CNS or skin. In aspergillosis, we have rhinocerebral aspergillosis, pulmonary aspergillosis, gastrointestinal, then cutaneous and disseminated aspergillosis. Proceed for this infection. The samples include blood, CSF, and bone marrow biopsy. Bulk will be another possible sample in these cases. The bone marrow biopsy samples will be tested for fungus stain, fungal culture, gene expert, MTB culture, histopathology. While the CSF for biochemistry, cytology, cryptococcal antigen, histoplasma antigen, galtomannan, fungus stain or in-dying, fungal culture, AFB stain, gene expert, MTB culture, there is mycotoplasma tuberculosis. While the blood or serum will be tested for viral load, CD4 count, cryptococcal antigen, histoplasma antibody, serum galtomannan, blood culture, fungal blood culture, and RK39 test. Blood culture, routine blood culture, that is 2 to 3 sets credited as for blood culture can detect the most implicated fungi such as Candida species, histoplasma, trichosporum, fusarium, or cryptococcus. Submit repeat 2 to 3 sets if there is no growth after 5 days of incubation in first submitted blood culture sets. Blood culture, special fungal cultures bottles are available like Bactec Myco, aphylatic culture bottles. A patient has had at least 2 rounds of negative routine blood culture sets and the patient has shown little to no improvement. Then the patient is immunocompromised, the patient has a histofungema, and the patient is on total parenteral nutrition. What was the specimen collection and transport? In systemic mycosis, tissue biopsy, put the tissue biopsy sample in a sterile container with small amount of saline, transport immediately to laboratory and don't freeze. Bone marrow is done in disseminated histoplasmosis. A sterile collection technique is used using a lysis centrifugation platelet tube or a heparin tube. Transport at a room temperature within 4 hours and not refrigerated. In respiratory samples include early morning sputum collected in a sterile container. Induced sputum, bowel, or tissue biopsy is preferred for diagnosis. Transport to the laboratory within 2 hours may refrigerate up to 24 hours, and 24 hours sputum collection is, however, not acceptable. How to interpret fungal culture is highly challenging. Relevance of Candida isolation from respiratory cultures, asymptomatic colonization in hospital patients, positive Candida cultures from sputum, bronchoscopic samples. Then gold standard is histology or pleural fluid culture. Nosocomial candidiasis develops in up to 25% of the patients with a urinary catheter for more than 7 days with a daily risk of 5%. It may represent contamination or colonization or UTI or even candidemia. Repeat the urine sample in such case. Evaluate the risk factors like diabetes mellitus, genitourinary, structural abnormalities, decreased renal function, and metabolic syndromes. Treating the predisposing factors helps in clearing candidiasis in many cases. When to treat the candidiasis? Symptomatic candidiasis should be treated Renal parenchymal infection should be treated. For critically ill patients, identify the candidemia or the primary source. What are the indications for antifungal susceptible testing? Candida glabrata isolated from blood or deep sites, mucosal candidiasis that is unresponsive to usual antifungal therapy, then invasive disease that is unresponsive to initial antifungal regimen, then invasive disease caused by rare fungal species for which antifungal susceptible patterns have not been well established or are unpredictable. Other tests include antigen detection, metabolite cellular components or enzymes, antibody detection, then molecular, it includes specific, because it is species specific, pan-fungal or commercial T2 candida or next generation sequencing. For antigen detection done for cryptococcosis, for samples is CSF, serum or urine, high antigen titers indicate poor prognosis. It is not useful for monitoring the response to treatment or duration of therapy. Galtoman is indicated for invasive exposure, which is screening test in high-risk patients who are asymptomatic and not on active antifungal prophylaxis. 1,3-beta-glucan is a pan-fungal biomarker. It is useful in specific situations like hemorrhagic cancer patients, neutropenia following allogeneic stem cell transplant, ICU patients. MANA is used for invasive candida disease. There is different sensitivity for different candida species. SL-beta-glucan all can be used as a rule-out disease due to high negative predictive value. How to approach the invasive fungal infections? Severely ill and immunocompromised. Risk factors include steroids, COPD, neutropenia, transplants. Risk factors include parenteral nutrition, broad spectrum drugs, invasive examinations. In case of risk, in such in the above risk factors, direct microscopy using calculofluor stain or histopathology or culture at 37 degrees Celsius for 2 to 5 days. Molecular identification using PCR-based tests. Then galtomanine test, where samples are from serum, BAL or ETA, that is endothelial secretions. Then serum beta-glucan test. 2 or more of these tests can be used. And then treatment, if it when diagnosed as invasive exposure, treatment includes triazoles, posaconazole, amphotericin B, liposomes, echinocandins. For this set of risk factors, we have direct microscopy, culture, serology, molecular identification again, and new methods like T2 MRI and MALDI-TOF. It is used to diagnose invasive candidiasis. And treatment modes include echinocandin, micofangin, triazoles, amphotericin B, and liposomes. How to approach invasive fungal infections? Severely ill and are immunocompromised. The risk factors include trauma, diabetes mellitus, stem cell transplant, prolonged neutropenia. Risk factors also include HIV infection, CD4 count less than 200, then, then organ transplant. And in case of the risk factors, direct microscopy or cultures or molecular identification. When I diagnose invasive mucormycosis, the treatment includes surgery or primary prophylaxis in form of posaconazole or first-line treatment like amphotericin B. If diagnosis is invasive cryptococcosis, the treatment is induction phase, amphotericin B, consultation phase includes fluconazole, and maintenance phase includes fluconazole. So these are the various risk factors that we have seen. We have seen in the first two sessions about the superficial fungal infections, subcutaneous mycosis, and here in this session we have seen systemic fungal infections. Take home messages then. There is no blanket test which can detect all the etiological fungal agents with acceptable sensitivity and specificity. Right specimen selection and taste order is crucial. Microscopy cultures are gold standard, but insensitive test. So non-culture based tests such as are available, but has a low positive predictive value in low prevalence settings. It is more suited to rule out the disease due to high negative predictive value. Organism is not isolated. Species identification sensitivity cannot be performed until blood cultures are positive. Repeated tests and combined 2 or more biomarkers improves sensitivity and specificity of detection. All in this session and from the set of 3 sessions on diagnosis of human fungal infections. Thank you.